So here what we need to do, which results in the blood loss at the rate of 2000 ml, disturbance of the blood clotting, choose the most suitable investigations. So this is the case of the, we have the suspecting what? We are suspecting the pregnancy. We are suspecting the pregnancy. So for pregnancy to be confirmed, we need to confirm about the HCG, human chorionic gonadotropin. So here is what we have is just gonadotropin, G for gonadotropins. So what we will calculate, we will check the rate, what the estimations or the rate of HCG will be calculated to confirm whether it is pregnancy or it is like if the it confirm the presence of the pregnancy. If it is pregnancy is there, so for that we will do the HCG test. Okay, this one we discussed also when we discussed the menstrual cycle. Then the same questions, same repeated question, that is the determination of the level of gonadotropins. Then in the woman of the 24 years, about the earlier normal menstrual functions. So earlier there was the normal menstrual functions. Cycles became irregular. So 24 years woman, earlier there is a normal menstrual function, cycles become irregular according to the test of functional diagnostics. What we are seeing is anovulations. The content of the prolactin in the blood. Now we are seeing there is prolactin in the blood is boosted, and whenever the prolactin is in the blood is boosted, it means the patient can having the anovulatory condition, that is infertility. Choose the most suitable investigations. So usual investigation that we do in case of the prolactinoma, when there is a hyperprolactinemia, so we do the MRI. But if MRI is not available, we do the CT, computed tomography of the hands, to check whether it is tumor or it is prolactinoma. So let's discuss in details about the prolactinoma. Let's discuss in details about the prolactinoma. देखो, what is prolactinoma? Prolactinoma, देखो, in prolactinoma what we will be having, in prolactinoma there will be the increase of prolactin level will be there, or we are seeing there is a hyperprolactinemia. There is what we will see there is a hyperprolactinemia will be there. Either it's hyperprolactinemia, and this hyperprolactinemia is mainly due to HPO axis. HPO axis means hypothalamus pituitary axis defect, or any problem in the hypothalamus pituitary axis. What we will see, hyperprolactinemia, or we can say increase in prolactin levels. There will be the increase in prolactin level will be there. In case of the, when we discussed about the secondary amenorrhea, when we discussed about what, which condition, secondary amenorrhea. So at pituitary level we discussed that there can be the, we having the one conditions at pituitary level that cause the secondary amenorrhea, and that was the prolactinoma. That was the prolactinoma that we need to understand. So see, we having the hypothalamus, and hypothalamus, what they will do, they release the gonadotropin releasing hormone. And that act on the anterior pituitary gland. So this one we know that it is released in the form of pulsatile GnRH, and that will act on the anterior pituitary glands. And when the anterior pituitary glands release the FSH and LH, and this FSH LH will act on the ovary. The ovary in further will secrete the estrogen, progesterone, and menses will begins. Now we having a one hormone, that is prolactin, that is the prolactin hormones. Now this prolactin, what they do, this prolactin hormone, what they having the negative, this anterior pituitary gland, what they secrete, prolactin hormone. This prolactin have the negative effect on the GnRH, have the negative feedback on GnRH, so they will block the or inhibit the gonadotropin releasing hormones. So tell me, if they will block the gonadotropin releasing hormones, so there will be no FSH LH will be there. Though no FSH LH will be there, that will lead to the infertility, or anovulations, infertility due to anovulation. Okay, if there is a no GnRH, the negative effect on the GnRH, what we will see, other than that, there is no estrogens or progesterone's level will be there, so no menstrual cycles or the no menses will be seen. No menses will be seen. Okay. Okay. If I will ask you which hormones or which neurotransmitter that inhibit the prolactins, so remember the dopamine, it inhibits the prolactins. This is sign of the inhibition. Dopamine inhibit the new prolactin. Dopamine inhibit the or the blocks the prolactin levels. Okay, understand these things. Hello. Might stop. Okay, it's clear now. Okay, till now it's clear. Then we will be having swords. Then we will be having switch conditions. See, it can be like the tumor or it can be the prolactinoma. If it is tumor, then we need to, like for example, we are having the prolactinoma. So prolactinoma is what? That is the prolactinoma. The prolactinoma will be having the prolactin secreting tumor. That will be the prolactin secreting tumor will be there. Prolactin secreting tumor will be theirs. So if prolactin level will be more than equal to 50 nanogram per deciliters, so we will call it as the prolactinoma. And when we do the MRI, what we will see? We will see this patient will be having the space occupying lesions on pituitary. We are seeing the space occupying lesions on pituitary glands. We know where the pituitary gland is situated. Pituitary gland is situated in the sella turcica. The pituitary gland, where it is situated? It is situated on the sella turcica. So we will, on MRI, we will see the space occupying lesions on the pituitary glands. And when there will be the prolactin level will be increased. When prolactin level will be increased, so these patients, what we will see? We will see the patient will be having the galactorrhea. We will see the galactorrhea. As we know that prolactin, it is more during the breastfeeding. It is more during the breastfeeding or the lactation's time. So the prolactin will increase. So there will be the more milk discharge from the breast. So we will call this condition as the galactorrhea. Spontaneous excessive milk discharge. We call this condition as the galactorrhea. Other conditions, what we will see, that is, we see there is a patient will be having the amenorrhea. We will see the patient will be having the amenorrhea. Other than that, we will see the patients will be having the infertility. If you are getting the questions and in the question you are getting the gonorrhea, you are getting the patients is having the amenorrhea and infertility. If this is things, the 99.99% the diagnosis will be the prolactinoma or hyperprolactinemia. Prolactinoma or hyperprolactinemia will be theirs. That you need to remember. Or remember also, this is the secondary amenorrhea that we will see. Which type of amenorrhea? The secondary amenorrhea we will see in these conditions. Okay, this is okay. You will remember this. Along with that, what we see in these conditions, this we will see if there will be the pituitary tumor. If there will be the pituitary tumor due to which we are seeing the prolactinoma also, or the increased prolactin levels also. So that will cause the visual disturbance also. That will cause the visual disturbance. But this is due to involvement of the pituitary glands also. So we will call the visual disturbance, and we will see there is a bitemporal hemianopia. We see that there will be the bitemporal hemianopia. What is this conditions? Okay, let me discuss it here. See, we having the eyes. This is little bit ophthalmology for understanding. We having the eyes. This is what we having the eyes. Okay, we having this field, that is the, and this field. This one is the nasal field. This one is the nasal fields. Okay, this one is the nasal field. And this this side is the temporal visual field. Temporal visual field. This one is the temporal visual fields. Above the side of we having, like when it making the orbit types, like we make the orbit here, like this is the orbit. So when the from the temporal fields, the rays that will come will go opposite sides, and here we having the, that is the nasal side of the optic, or the optic of the orbits. The nasal visual fields, we see that this rays will go on the opposite sides, on the temporal sides, which take on the temporal sides, and from the temporal sides we will be having the temporal fibers. We will get the temporal fiber that will go ipsilaterally. The same side, like for example, we have the nasal. On the nasal side will go to the opposite sides. The rays from the nasal side will go to the opposite sides and will reach to the temporal fibers. And temporal side will be having the temporal, what we having the temporal fibers, and these temporal fibers will be go ipsilaterally. Then on the nasal side, this one is the nasal side. On the nasal sides of the orbit, we having the nasal fibers. We having the nasal fibers. These nasal fibers will go and they will cross each other. They will cross. Where they will cross, they will call this condition as the optic chiasma. We will having the optic chiasma. So if any conditions, like there can be the craniopharyngioma, the pituitary tumor, the prolactinoma. So this, at this point we will see this type of the tumor. If this type of the tumor we will see at this point, so the nasal fibers will be gone. So tell me, if the nasal fibers will be gone, which visual loss will be lost? Temporal visual field will be lost. So person will not able to see the temporal views. He will able to see only the nasal views, but the temporal views will be blank from his eyes. So we will call it as the temporal, bitemporal. Temporal, bitemporal. Okay. Then half side. This is the half side of this right eye, or half side of this. So bitemporal hemi. Anopia means like visual loss, absent of vision, anopia. So bitemporal hemianopia. So this condition we seen in can there is a problem in the optic chiasma. So there is two things, like the craniopharyngioma and pituitary tumor. The craniopharyngioma, like for example, if the inferior fibers will be affected or the superior fibers. For now, just remember, if any craniopharyngioma or pituitary tumor, what we will see, the nasal fibers will be lost, and these due to these nasal fibers, which visual field will be lost? That is the temporal visual field will be lost, and we call this condition as the bitemporal hemianopia. Okay, this is done. Is this clear? That's why we will be having here visual disturbance, and visual disturbance what we are seeing, that is the bitemporal hemianopia. So this is mainly due to like involvement of the, when there is association of the pituitary gland. So at that time we are seeing there will be the bitemporal hemianopia will be there. Okay, I hope this is clear. Then we are having the, like if we talk about the types of prolactinoma. So there is the two types. It can be the macroadenoma. It can be the macroadenoma when the size will be the more than equal to 1 centimeter. More than equal to 1 centimeter. It can be the microadenoma. It can be the microadenoma when the size will be less than equal to 1 centimeter. So more than 1 centimeter or equal to 1 centimeter macroadenoma, less than 1 centimeter, that is the microadenoma. For diagnosis, what we will do? For the diagnosis we will do the MRI. For diagnosis we will do the MRI. If MRI is not available, we can do the CT scan, CT of the head. We do the CT scans, but most probably we do the MRI only. What is the treatment we will giving? That if you having the microadenoma, if you having the microadenoma conditions, so the drug of the choice for microadenoma, what we will giving, that is the cabergolins. Cabergolin. If the condition is of macroadenoma, if condition is of macroadenoma, so if the macroadenoma conditions, then in that conditions we will giving the drug of the choice the same like the cabergolin. But if size is more than, if size will be more than equal to 3 centimeter and patient is not having, like the patient is not responding to the cabergolin, so we will prefer the surgery. What we will do? The surgery, we will remove the tumor and then we will ensure that patient is responding. Okay. There is one more question. What is the drug of the choice? If drug of the choice for increase or hyperprolactinemia, drug of the choice for hyperprolactinemia, drug of the choice for hyperprolactinemia in infertile women, in infertile women. So what is that? That is bromocriptine. That is the bromocriptine. Okay, that will be the bromocriptine, that will be answer. Okay, so this is the case of the secondary amenorrhea at the pituitary level. The secondary amenorrhea at the pituitary level, we have the prolactinoma, the prolactin secreting tumor. If prolactin level more than 50 nanogram, MRI, the space occupying lesion on the pituitary gland, prolactin increase, galactorrhea, secondary amenorrhea, infertility, visual disturbance, and the two type of prolactinemia. There is a macroadenoma or micro. More than 1, less than 1. Gonorrhea plus secondary amenorrhea, infertility, high chances that diagnosis will be the prolactinoma. Okay, I hope this is clear. There is one more condition that is associated. We have the Sheehan syndrome. That is the Sheehan syndrome. At the Sheehan syndromes, see the Sheehan syndrome, it's again the cause of the, like the, it's secondary amenorrhea. Sheehan syndrome. See again that is the important topic for your exam. So Sheehan syndrome, what we will see, in case of the Sheehan syndrome, we are having the postpartum necrosis. The postpartum means after the delivery. So we will see the postpartum necrosis of anterior pituitary. The postpartum necrosis of the anterior pituitary will be seen due to excessive PPH, due to excessive postpartum hemorrhage. Due to excessive postpartum hemorrhage, what we will see, the postpartum necrosis of the anterior pituitary due to excessive PPH will be called the Sheehan syndromes. So during the pregnancy, the anterior pituitary size increase. The anterior pituitary size increase because we know that it required for the formation of FSH, LH, then estrogen, progesterone. So for that we need the requirement of the anterior pituitary. So this anterior pituitary will increase. Now what happens when during the delivery or after the delivery, the woman get the PPH. After delivery, if she undergo the PPH, so the blood supply to all organs will decrease. The blood supply to all organs will decrease. We know that in the case of the PPH, the blood pressures will be decreased and the female can go into the hypovolemic shocks. So blood supply to all organs will decrease and including the pituitary also. The pituitary's blood supply will also decrease. And if the pituitary blood supply will decrease, it will lead to the necrosis of the anterior pituitary. It will lead to the necrosis of anterior pituitary. Okay. And what we call these conditions? We call this condition as the Sheehan syndromes. We call this condition as the Sheehan syndromes. In case of the Sheehan syndromes, when we do the diagnosis, so diagnosis again we do with the help of MRI, and in MRI what we see in case of the Sheehan syndrome, we see the empty sella turcica. We see the empty sella turcica. I hope everyone of you know what is the sella turcica. It is the location where the pituitary glands located. So this is the empty sella turcica will be seen in case of the Sheehan syndrome. The empty sella turcica will be seen in case of the Sheehan syndromes. Okay. Let's see this flow chart. See, if we having, like for example, if we talk about the hormonal study, we did the UPT, we did the UPT test, we did the TSH, thyroid stimulating hormone, and prolactin. If all these hormones, if all these things are normals, if all these things are normals, so in that case we will do the progesterone challenge test. This is, we will do the progesterone challenge test. We will give the medroxyprogesterone acetate. Give medroxyprogesterone acetate for 7 to 10 days, and then we will withdraw these drugs for 7 days and then withdraw. If in this period, if we see that the bleeding is present, if in this period we see the bleeding is present, then we do the make the diagnosis. Okay, this patient can having the PCOS, or this patient can having the anovulation. This patient can having the anovulations. If bleeding is absent, so at that time we will do the next step will be the, we will check the progesterone along with the estrogen also. So estrogen and progesterone test will be done. The estrogen and progesterone test will be done. So in estrogen progesterone test, what we will do, in estrogen progesterone test, we will give the estrogen for 21 days. We will give the estrogens for 21 days and progesterone for last 10 days. We will add the progesterone for last 10 days. Okay. Because estrogen, progesterone, they will act on the ovary, hypothalamus and pituitary. Now we will see if the bleeding is present or not. If bleeding is present, so we will check about the FSH levels. If it is due to FSH levels, or if we will check the value of FSH also, so we will call this condition as the, if more than 40 international unit, we will call it the premature menopause. We will call this condition as the premature menopause conditions. But if FSH is normal or decrease, if FSH is normal or decrease, we will check about the pituitary hypothalamus. We will consider it the pituitary hypothalamus problems. So after that we will do the MRI. And in MRI, if we are seeing, what we are seeing, empty sella turcica. So the empty sella turcica, what will be the answer? That will be, you will write. Then in case of the space occupying lesions, what will be the answer? If you are getting the space occupying lesions, so that is the prolactinoma. If you are getting the MRI is normals, then the problem will be in the hypothalamus. There is a hormonal problem with the hypothalamus will be there. If you are getting the bleeding is no bleedings, if no bleeding after all these steps, so we will call these conditions that there can be the uterine cause can be possible. And uterine cause, we know what is that? Yes, that is Asherman syndrome, fibrous band formation that we studied. Asherman syndromes can be there. Okay, I hope this is clear. Okay, the empty sella turcica, what will be the answer? That will be the Sala. That will be the answer. What will be the answer? Sihan syndromes. That will be the Sihan syndromes. So this answer will be the Sihan syndromes. Okay. So you need to remember, if empty cella trasica, Sihan syndrome. If space occupying lesion is there, so we will consider it as the prolactinoma. We will consider it as the prolactinoma when we answer. Okay. Now let's come back to the questions. So earlier there is normal menstrual cycle become irregular according to the test of the function diagnostic, and the cycles become irregular because there is a decrease in FSH or LH, and estrogen everything will be decreasing. According to test there is anovulation. Anovulation I told you, due to decrease in FSH and LH will be there. The content of the prolactin in the blood is boosted. So choose the most suitable techniques. So the most suitable technique according to this question, and the most correct answer will be the computed tomography of the heads. So normally what we do the MRI, but here the answer no MRI in the question. So what we will choose? We will choose the computed tomography of the heads. Okay, is this clear? Then the next question is about the labor that we did not study till now. So we skip this question for now. We will discuss maybe tomorrow, and after that we will discuss it. The same question. Now let's come back to the question number . Did I talk to you the molar pregnancy, about the molar pregnancy? No. Okay, so let's today discuss about the molar pregnancy. Okay, and after that we will discuss. There are how many tests to tolerance to the glucose? Just a second, so I can check the questions. Cholera, chorionics, SGOT. Okay, let's discuss the molar pregnancy. And after that I will ask you the questions from the, because you got the 2 days, and I hope in the 2 days you revised everything what we discussed. So I can ask you from anywhere means from pedia, rheumato, and the obstetrics parts with that till now what we studied. So I will discuss everyone with the 10 questions after this. Okay. Then there will be the molar pregnancy. What is the molar pregnancy? Molar pregnancy occur due to, like, if having anyone having the abnormal fertilizations, so that is mainly will lead to the abnormal due to molar pregnancy. Like बच्चे की जगह अगर अंगूर के गुच्छे बन जाए, बच्चे की जगह क्या बन जाए? अंगूर के गुच्छे, तो उसको बोलते हैं क्या? मोलर प्रेगनेंसी. ठीक है. The cause is due to abnormal fertilizations. It's occurred due to abnormal fertilizations. What is the definition of this? It is abnormal proliferation of and degeneration. The abnormal proliferation and degeneration of chorionic tissues. And chorionic tissue, like for example, so what we are having, the which chorionic tissue we are having? Syncytiotrophoblasts, and cytotrophoblast. Cytotrophoblast and the cytotrophoblast, these are the abnormal proliferation and the degeneration of the chorionic tissue. In this condition is the it is the benign conditions. It is the benign conditions, but it having the malignant potentials. Because of abnormal proliferations, it having the malignant potentials means it having the chances to become the malignants. Then we having the types of molar pregnancy. We having the types of molar pregnancy. So there are mainly the two types. We having that it can be the complete mole. It can be the complete mole, and we can also call this condition as the vesicular mole. We can also call this condition as the vesicular moles. And it can be the conditions like the partial moles. It can be the partial mole conditions. So complete mole or the partial moles. This can also called just simply the moles. If they will give you the question simply the mole, they are talking about the complete moles. It can be called the mola or hydatosa. It can be called the hydatosa also. Hydrated cyst, hydatosa, or we can also call this as the hydatiform moles. Hydatiform moles due to hydrated cyst. So this is what the cut is complete mole. What is the risk factor? The risk factor, again the history of the same thing. The risk factor will be the if there is a history of previous molar pregnancy. If the history of the previous molar pregnancy, so that will be the risk factor. Other than that, we will be having the age. The age will be more than 35 to 40 years, and the 40 years will be more than the 35 years. Okay, and in this condition, remember we will be having the deficiency of which carotene? Deficiency of beta carotene. Deficiency of the beta carotene, which is present in the vitamin A, and along with that we see there is a folic acid deficiency also will be seen. So these all are the risk factor that we seen in case of the molar pregnancy. There can be the it is associated with the ABO blood grouping also. The female having the A blood group or the male having the O blood group, the cause is idiopathic, but for some reasons there can be A blood group female and O blood group male. They also having the risk about the molar pregnancy. Along with that, the smoking also, that is again the risk factors. Then it is most common in the developing country, and the country that is most seen the molar pregnancy, that is the Philippines. That is the Philippines. Okay, now questions will come from the complete moles. Complete mole, or we also call the hydatiform moles. In case of the complete moles, if empty ova is there, and if the empty ova will fertilize with sperm, so of course what they will make? Angur ke guchhe, the bundles of grapes. The empty ova plus sperm. So when they will fuse or they will fertilize, what they will make? They will make the zygote, and this zygote will be 23x will be there, 23x, and this is derived from the father. This is derived from the father, or we can say this is the when the duplication, the androgenesis or the duplications will be there, it will become the 46xx, and that will be the diploid. Now what will be the outcome? We will see the outcome will be the complete abnormal proliferations. Outcome what we will see? The complete abnormal proliferation and degeneration. The proliferation and degeneration of chorionic tissue. So what we will see in this condition, the uterus is filled with the grape-like vesicle. The uterus is filled with the grape-like vesicles. Uterus is filled with the grape-like vesicles, or we call it the chorionic tissues. We called it as the chorionic tissue will be there. Then we will be having, so these are the grape like vesicles that we call the अंगूर के गुच्छे, ठीक है, the bundle of grapes. Now in case of the partial moles, if you are having the case of the partial moles, in case of the partial mole, the normal ova, this normal ova is fertilized by 2 or 3 sperms, fertilized by 2 or, this is like 2 will be more, 2 will be like the most commonly they fertilized by the 2 sperm, but they can be fertilized by the 3 sperm also. If the normal ova will be fertilized by the 2 or 3 sperms, what they will make? They will make the 69XXY. That will become the triploid condition. That will become the triploid conditions. So in the partial mole, what we are seeing? Partial abnormal proliferation and degeneration of chorionic tissue. The partial abnormal proliferation and the degeneration of the chorionic tissue will be there. Okay. In case of the complete mole, there is a complete abnormal proliferation. Here, but we will see the partial abnormal proliferations. Here, the fetus will deliver, but fetus develop, and usually fetus will develops, not delivered. It will develop. The difference between the develop and delivered. The fetus will develop, but usually it will die around 10 weeks. Usually die around 10 weeks. And in that conditions, what we will see? The multiple anomalies will be seen. The fetus will be seen having the multiple anomalies. And 10 weeks, what we know? We know that in the 10 weeks, the corpus luteum is live, so this baby will be live due to there will be the fetus will also live due to corpus luteum. And we will see the abnormal hydropic placenta. What we will see? Abnormal hydropic placenta, and hydropic means water and water means cyst. So we will see there is a cystic space in placenta. What we will see? The cystic space in placenta will be seen. So if you are getting the like complete moles, in the complete mole we are seeing the grape like vesicles, but if you are having the condition of the partial moles, we see there is a cystic space in the placenta. And also remember the symptoms, you will see there is irregular bleedings per vaginals. The symptoms, what will the symptoms we will see? The symptoms we see in the conditions, this is the irregular bleedings per vaginal. The irregular bleeding will be seen per vaginal, and this is associated with the passage of grape-like vesicles. Associated with the passage of the grape-like vesicles. And also remember, this bleedings will be looks like the prune juice. There is a juice called prune. Search in the Google prune juice like. It will be the prune juice like color. Prune juice like color bleeding will be there. Along with that, these patients will be having, because it's a pregnancy, so of course there will be the amenorrhea will be there. This patient will be having, okay, this is molar pregnancy is associated with the SCG also, and this SCG we know that it is associated with the hyperemesis. The hyperemesis, but in case of the molar pregnancy, the hyperemesis gravidarum. What is that? Excessive nausea and vomiting will be there, because SCG level will be very highly boosted in case of molar pregnancy. That's why we see there is excessive nausea and vomiting will be seen in case of the molar pregnancy. Hyperemesis gravidus will be there. Okay. The irregular bleedings per vaginals will be seen. And when we do the ultrasound also, the ultrasounds, these grape-like vesicles will be looks like the snowstorm appearance. They will give you the complete sentence about it, that when the patients is done the ultrasounds, in ultrasound this we are getting the snowstorm appearance and the grape-like vesicles are seen. So which type of the pregnancy is that? So you need to answer what is that? Hydatiform mole is there. Okay, and they can give you in the question if the hydropic cyst is given in the they did the this patient is going under the ultrasounds. In ultrasounds, what you are seeing, hydropic placenta or the hydropic cystic space you are seeing in the placenta. So what your diagnosis? The diagnosis will be the partial mole will be there. Okay. And also remember, like I told you, that complete mole or whether it is the partial moles. In complete mole, there will be the beta HCG level will be more than 10 ki power 5 international unit per liter. In case of the partial mole, it will be less than, in case of the less than 10 ki power 5 international unit, but again that is the high value. So beta HCG more than 10 ki power 1 lakh international unit. You understanding? So there will be size of the thecal lutein cyst will be increased, hyperemesis will be, thyrotoxicosis will be increased. Why the thyrotoxicosis? Because it associated with the alpha subunit. Thyrotoxicosis will be there, and thyrotoxicosis, it is associated with alpha unit of HCG, and this alpha unit of HCG is similar to the TSH, hormones. That's why there is more hydropic malignant potentials here. The malignant potentials will be high. In this condition. The malignant potentials will be high. Hydropic degenerations will be more. In these conditions. Okay. So this, and if we talk about the partial mole, so partial mole, write it like that, partial mole. So in the partial mole, what we are seeing, less than 10 ki power 5 international unit per liter. This will be, if I am making the 2, thyrotoxicosis will be more, malignant potentials will be more. So in case of the partial moles, there will be the decrease, there will be increase, or there will be increase. So write it like this also. So that they increase in both, but more in case of the complete mole. And what is the management we will do? If no birth required, so in that conditions we will do a total abdominal hysterectomy. If like multiparous women, in case of the multiparous women where the no child required, so multiparous we will do the total abdominal hysterectomy. Then in case of the nulliparous, what we will do? We will do the suction evacuations. Will be done. Okay, and along with that we need to we need to monitor the beta HCG levels. Monitor the beta HCG weekly till 3 consecutive reports becomes normal. So just remember, we will monitor the beta HCG levels. We are having the multiparous, the nulliparous will be there. So that was about the molar pregnancy. So I think there was one question about the molar pregnancy. At onset of the severe eclampsia at 16-week gestations might be caused by the, so again the severe preeclampsia. So severe preeclampsia, again this is the risk factor that we seen in case of the like hydatiform moles. Okay, like where you wrote these things. Yeah, they also increase the PIH. They also increase the pregnancy induced hypertensions, or again that is associated with the preeclampsia condition. So onset of the severe preeclampsia 16-week gestations. So we are seeing that is seen in case of the hydatiform mole. Okay, the rest questions we will do tomorrow. Now we need to finish it very quickly, because most of the topics we covered. There are some topics left about like the breast, because breast is also become very common, and good questions come from the breast topics. So we will discuss the breast topics later on, and I think most of the questions that we need to discuss will be discussed, and the topics has been covered. Now we have just questions left, and I hope you revise about the yesterday. So I will ask you now one by one each and every questions. Okay, from to like the rheumatology, PD, and from obstetrics that we discussed already. Okay, so you who left the class to just now? Okay, so you can leave the class, and I will just mention your name, and you need to just join the class at that times. I will start from the name first, Anurag Saini, so it will be like alphabetical order. Okay, so you don't need to waste your times. Just keep revising till that times, and I will just keep asking for 10 minutes, and after that you can continue. Okay, so you can just left the class and revise all the topics. Anurag Saini, just stay now, or all those students left. Hello.
भैया सही चल रही है भैया क्या हाँ भैया पीडीएफ वैसे जनरली कर ही लिया आज कुछ पेपर भी लगा के देखे थे हाँ हो तो रहे हैं भैया मैंने 2021 का पेपर लगाया था शायद मई का या शायद ये कुछ डेट दो थे उसमें क्रोकोलॉजी में तो वो लगा के देखे थे अराउंड 70-80 क्वेश्चन लगाए थे
से ज्यादा ना उस पर फोकस करो, जो टेस्ट सेंटर की जो वेबसाइट है ना, ठीक है, जो मैंने लिंक दे रखा
अच्छा
है उस पर ज्यादा फोकस करो। मैं क्वेश्चन आंसर कुछ नहीं सुनने, ठीक है, मेरे को जस्ट डिस्कस करना था वन बाय वन सभी के साथ कि कैसे क्या चलता है।
अच्छा अच्छा
ठीक है, तो ये क्या है
जी
कि
भैया
तुम उस चीज पे ध्यान दो कि क्या करना है। ठीक है, जो टेस्ट सेंटर वेबसाइट है ना, वहां से क्वेश्चन होगा कि डायरेक्ट क्वेश्चन आएंगे। ठीक है, दूसरा मुझे
जी भैया
अभी पहले से अच्छा पढ़ाई, मतलब पहले से अच्छी चल रही है या फिर अभी अच्छा चल रहा है, कैसे चल रहा है?
हाँ मैं आपको बताऊं जो इनिशियली जब हम तैयार कर आपसे ज्वाइन करने से पहले